guest speaker for clinical nurse consultant from Advanced Project. Hi, John. I'll give the floor to you.
Thank you very much, Maria, and thank you so much, Dorinka, and thank you so much for everyone who attended today. At the same time, probably watching the recording. I'm John St. Martin. I work as a clinical nurse consultant in palliative care based in Sydney, and I'll be talking about the Advanced Project, which has been funded by the Department of Health and Aged Care since 2016. Primarily started in general practice and working with GP nurses, practice managers to start conversations, to have resources and tools to start conversations about advanced care planning and palliative care in general practice. And this has now extended to aged care. So we've developed new resources and tools to use for initiating conversations on advanced care planning and palliative care for people living with dementia in particular. So the goals of the Advanced Project is to help build confidence and skills for people working in aged and primary care, to initiate the conversation about advanced care planning for people living with dementia, regardless of the stage of dementia, to empower and help prepare family members to really advocate for the person's end-of-life care wishes for the future, to help identify people living with dementia who would benefit from palliative care assessment of their needs, and also facilitate timely referral to specialist palliative care and other services. Many of you working in residential aged care would be very familiar with this document, the Royal Commission, and really highlighting how people involved in providing direct care to people living with dementia in aged care undertake regular training about dementia care and palliative care. I've got this beautiful definition that kind of encapsulates the beautiful essence of advanced care planning and people living with dementia from a recent conference in Singapore, actually, highlighting that advanced care planning in people living with dementia was defined as a communication process adapted to the person's capacity to be involved, which then continues on to have this conversation with family members when they no longer have the capacity. So it's got a really strong relationship-centered definitional framework for advanced care planning, which really supports inclusivity, like including the person themselves and also their family members, who becomes their substitute decision maker in the future. In the development of a lot of these resources, we've done a literature review in partnership with Care Search and Flinders University. We've done extensive interviews with many people, experts around Australia, including people working in residential aged care, clinical managers, GPs, including people living with dementia and their family members who have lived experience of looking after someone living in dementia, to ensure that the resources developed are sensitive and appropriate and relevant to their care. And I'll share some of the interview quotations that we received from the medical and nursing staff. They mentioned that there is a significant gap in the staff, family, and individual understanding towards end of life or towards the life-limiting nature of dementia. And until general practice, the community and aged care workers understand this and the disease trajectory, the prolonged disease trajectory, end of life planning cannot really begin. Another quotation was from a research psychologist who stated that advanced care planning was often triggered by a serious incident or decline in an older person's health. So it's quite reactive, resulting in a time-pressured process rather than an early initiated and ongoing conversation. From a primary health network participant, they mentioned that many providers consider incoming residents living with dementia as too late to even engage in advanced care planning conversations. And as we know, this is probably in part the sort of the true picture of what's going on, that many people living with dementia would prefer to stay at home for as long as possible. Hence, when they come to residential aged care, they probably have more complex care needs and perhaps far more advanced that their capacity is no longer that permits them from participating in or engaging in advanced care planning discussion. So to achieve these goals that we've mentioned earlier, we've developed dementia-specific resources to start advanced care planning and assess palliative care needs for people living with dementia. We have free e-learning available that is accessible. We have a 4 CPD hour e-learning for clinicians and managers, and a 2 CPD hour e-learning for care workers, assistant nurses, care staff working. And also, we also have the train the trainer mentoring support, and that'll be with me. So I'll be more than happy to do a 1 hour session with your care home with the team, and then take it from there. So we'll do the initial session. I'll introduce you to the advanced project resources, and then from then on, we can progress it there. So in a way, it kind of loops it up. You've got the resources that you can access, you've got the e-learning, and then you have a person that you can really speak directly about these resources. So to access the advanced project resources, you can either type in Google advanced project, and then that should come up, or you can also equally scan the QR code on the screen, and that will take you directly to the website where you can access all the resources and e-learning for free as well, and our contact details too. So next, I'll be just outlining some of the key steps that we suggest when starting conversation about advanced care planning and palliative care. So the first step is to identify the approach required, followed by initiate advanced care planning, assess palliative care needs, and ongoing evaluation. As you would notice, it's quite text heavy, and we tried to simplify this as much as we could to make it more user friendly, but really just demonstrate the complexity in terms of having this type of conversations. And you would notice that it's quite colorful as well. So the green column is focusing on early dementia. The orange column is focusing on moderate dementia, and the purple column is focusing on advanced dementia. So I'll go through them in 4 different steps just to give you an overview of what's available. So the first step is to identify the approach required. When we're identifying the approach required, we're not strictly wanting you to diagnose is it early dementia, moderate dementia, advanced dementia, but really just understanding their capacity to be involved, to communicate their symptoms and their concerns. Generally, for someone with early dementia, they're able to make their own decisions, come up with their own advanced care directive, and even nominate their own substitute decision maker. For someone with moderate dementia, generally they would need a bit more support because sometimes focus could be an issue. There could be some fluctuation in terms of their decision making capacity. So it's good to have someone supporting them, like a family member, a care partner, or someone. For someone with advanced dementia, a substituted approach would be required, wherein they're no longer able to communicate or make decisions about their future health wishes as well. Once we've determined which approach we'll be using, we will stick in that column. Let's say if we focus on someone with advanced dementia, we'll just look at purple and then go through there. So the next step would be initiate the advanced care planning discussion. Often, as a staff member working in aged care, and I've worked in aged care as well as a care worker and a registered nurse and a clinical manager, the first fear I have related to advanced care planning is if I have to start it. And often it's just so hard. Where do I begin? How do I start this conversation? So we've got resources and tools for staff members who are reluctant to start this conversation, so they feel a bit more guided in terms of knowing the right thing to say or eliciting the right information they want to get. Because often that's the fear. I don't want to upset them. I don't want to make them feel uncomfortable. At the same time, the question that I would get is, where do I start? What do I say first? So we've got the resources that staff members can use, but equally, we also have resources that we can give to family members, to residents themselves. So for someone with early to moderate dementia, as you would notice, there's a green line here indicating early dementia, and green and orange line here indicating this is appropriate for someone with early to moderate dementia. Something we can give with them because they won't be able to take in everything we say in one conversation. So it's good that they can take something with them. And this purple one is probably a lot of people working in residential education love this one. It's their favorite because it's something they can give to family members. And this is really carefully worded to make sure that that the person completing this on the person on someone else's behalf is reflecting on that particular resident's wishes rather than themselves. How we make decision for ourselves is very different for someone else. So I think consistently reminding them, what would you think this person would have wanted? What are the values? What are important to them? The type of question that would be kind of ask them to help them complete this booklet and help them prepare to actually have the advanced care planning meeting with you, or the other healthcare team members. When talking about palliative care, I really like this statement from Palliative Care Australia, stating that the person living with dementia can require a different care to people with other life-limiting conditions. In part because we know the long trajectory that sometimes happen. It can be unpredictable. There's issues with decision-making capacity. There's issues with communication, that they aren't able to communicate anymore. Which exactly are the symptoms that are causing distress? Is it pain? Is it nausea? Is it breathlessness? It's hard for them to communicate that now. And the lack of community understanding of the condition. And I think this is really a key highlight there, is the last statement, because I remember when I first one of my early experience in doing advanced care planning in residential aged care, a family member asked me, "Why do I need to talk to you about this, John? My mom don't have cancer. My mom only have dementia." So I guess in terms of understanding that dementia is still a life-limiting condition, and people can live with dementia and live well with dementia, but equally people could die with dementia and also die from dementia or of dementia. Recognizing that dementia, as of this year, is the second leading cause of death in Australia, the leading cause of death for women. When assessing palliative care needs for someone with early to moderate dementia, it's important to consider other health conditions that they have that may indicate a trigger palliative care. That's why we recommend using a surprise question for someone with early to moderate dementia, or using the speak to or speak for all, as it gives us a few prompts to consider. Does this person require palliative care needs now? This palliative care now? Asking yourself, would I be surprised if this person dies in the next 6 to 12 months? If your answer is no, it's probably a good time to start looking into, what do I need to have in place for this person? Like, do I need to update the care plan? For someone with advanced dementia, and this is from Dementia Australia um, booklet talking about palliative care, a palliative approach for someone with advanced dementia is appropriate. However, we could not find a tool that is simple enough that care workers, care staff, and family members could use to actually help them communicate the distress that they observe for someone with advanced dementia that may indicate palliative care needs. So this tool is really focusing on that one. It's a one-page document back to back. It's really asking you, what kind of distress am I noticing with this person right now? And then, how worried am I right now? How distressed do I think this person is? If you answer between 0 to 3, then that's the end of your assessment or your observation. If you answer 4 and more, then you would go to the following page. And the following page would ask you questions such as, what do I think might be causing this distress to this person right now? As they aren't able to communicate themselves much easier, having advanced dementia, this is really relying on how well the person knows, or the staff member know, or the family member know this person. It's like, is it pain, or is it when they're bored and lonely they become more distressed, or is it when you're giving the medications, or is it when you're doing the showers and all that thing, or is it when it's noisy? So all this, a number of factors might be triggering distress for this person. Once we've established that one, we will find out which are the top 3 main causes of distress for this person. Then we will list it down. Any other concerns? Do the family have any concerns keeping it collaborative? Any particular time of the day or situation where this stress is worse? And what do you think would help this person, or what do you think has helped in the past to alleviate some of this distress? So that's what we call the distress observation tool, or the DOT tool. And lastly, I want to talk about sending in referrals. So we've got a referral triage tool to understand, okay, well, how do I know if I need to make a referral to specialist palliative care? So this would be a tool that you can use to kind of help determine that. And what if a referral to specialist palliative care is required? How do I communicate that to the resident or family members? And we've got some communication tips on how you can do that as well that you can access. The last step is ongoing evaluation. It's not because we have done it, we forget about it. It's really we're just prompting to align with your individual processes within your organization. To if you do review every 3 months, every 6 months, then we'll align with that one. And certainly when things have changed, when there's new symptoms, there's new issues that arise, or there's changes with the person's ability to make decisions, is when we would advocate for you to review and do another assessment. Ultimately, we want to make sure that people living with dementia are included and have the opportunity to have discussions about their preferences and needs and wishes um, for future care, and have access and support from palliative care for themselves and their families and the carers. Just reminding that e-learning is available and free. So if I could highlight that once again, please go to the website. And if you're interested for more information and like to learn more about these resources, please feel free to flick me an email either via Maria or Dorinka and the team, and we can also link up then and do a session. Thank you once again for your time and attention.
Thank you, John. Does anyone have a question for John? No? John, how is it different than the one developed by University of Wollongong?
PACOP.
Yeah.
So PACOP, so both of us are palliative care, National Palliative Care Project funded. So PACOP is focusing on in residential aged care at the moment, and really focusing on using assessment tools for palliative care, but generally for aged care. So whereas for Advanced Project is really focusing on people living with dementia, regardless of whether they live in residential aged care or a home.
Community. Okay.
Yeah, or a community as well.
Yeah.
And Advanced Project have a stronger focus on starting the conversation in terms of advanced care planning. So really enabling staff to have that resource and build their confidence to bring up the conversation. Because what happens is they will wait until someone brings it up because it's quite uncomfortable. And then equally, maybe the resident or family members are waiting for someone to bring it up. So I think just giving more opportunity to actually do it much sooner would be the key focus. But we do work with PACOP as well. So it's palliative aged care outcomes collaborative is what I remember. Yeah.
And Judy has a comment that I didn't know about this program. So thank you, John.
Thank you.
Yeah, because it is a very handy tool for aged care workers, and it was one of the identified needs, upskilling needs for aged care workers as well as community workers to actually understand when to initiate that conversation. Yes.
Absolutely, and I think it's just highlighting that advanced care planning conversation is not necessarily a clinical conversation all the time. Other team members can be involved in it. It could be pastoral care, it could be care workers who've got appropriately skilled, and it becomes a clinical question. And that's when we pass it to registered nurses and other clinical team members. But overall, there's a number of aspects of advanced care planning that is beyond CPR or no CPR.
Yes. So does that mean you also deliver this kind of training to community groups?
Yep, we do.
Brilliant. Okay,
Yeah.
can I book you in?
Sure, absolutely, yes. I did have a few presentations with different home care providers to talk about how can this be integrated, and I think the interest depends on how many of their clients actually have a diagnosis of dementia. But equally, some of these resources would give them skills that can be applicable and translatable to any circumstances.
Yeah, and I mean, with our compassionate community connectors, they are community people living in the community. There could be their retired professionals, um, um, aged care workers, or community leaders, and if they have this sort of training, they can actually identify and assist, hey, and signpost to seek formal supports. It's very
Absolutely.
easy to understand as
Mm.
well.
Yeah. And that's the vision, is to make sure that it's accessible, that it's
Mhm.
respectful, that it's sensitive enough, but at the same time practical and useful for
Yeah.
people. Because the real focus here is quite early, quite upstream, focusing on early introduction of advanced care planning, because and allowing for us to actually assess the person's readiness, because often in aged care, and this is my experience working in aged care, and a lot of people that I've done this presentation with would say to me, how we do it is on admission, here's the advanced care planning form, complete it when it's ready.
Yeah.
And those forms can vary depending on where you are, and some of them can be really scary, and that could really put up the whole conversation altogether. But if
Mm.
we kind of introduce it bit by bit, scaffolding it, I think we can have a better outcome from there.
Yeah, and also the readiness for staff to actually
Mm,
initiate the conversation and have confidence, because it takes
absolutely.
time. We're like, ah,
Absolutely.
yeah.
It can be really scary. I remember running away
Mm.
from it, saying, I'm going to do a wound dressing.
I'd rather
Because I
have
didn't
the
want to do
wound
it. Oh,
dressing.
sorry. Buzzers. There's buzzers there. I got to go.
And
Um,
when I did the practice manager training, it goes into some really fine detail about right down to making sure that there's a room available to have the conversation and getting your reception staff just to hand the forms out to people as they come through the door and that sort of thing. So it gives a lot of really practical advice rather than just the theoretical side of it. So I found that section that I did was really really informative as well.
excellent. Excellent.
Judy, do you have other comments, and Winston?
That's
I don't like
correct.
talking. Yep.
Yeah, that's correct. So the e-learning, so both currently, because the government likes to make sure that they can track how many people are accessing the resources and
Mm.
e-learning. So currently, both e-learning and the resources, you kind of need to register. It helps me when people register individually, but as a group, it's fine as well. If it can help the groups that way, and I can kind of touch base with them in the future, whether if it's a trainer session, because we don't suggest that you use all of these resources in your practice. Pick one or two that might be helpful for you, or even if it's just as an education component, that's fine as well, because different organization would have different approach that might duplicate this already, or if it's something that's a gap for their practice, then that's something that we can work together as well.
I just
And
wanted to.
do the
Sorry.
Darinka, do the nursing and GP ones still have CPD points attached?
I'm not sure for this year, because currently the real focus is on the aged care for
Yep.
this round. Yeah,
Mm-hmm.
the funding that we've got is focusing for aged care and dementia currently. Yeah.
Can I
And
just
the
double check?
yeah.
Sorry, with training, so access to mental specific training. I think
Mm.
if you go into it and then you try to download it, it sort of times out. So you need to register before you start downloading any of that. Is that correct? I just want to make sure I'm providing the right information to everyone.
Also,
I-
in the e-learning.
Yeah, I went to enroll now,
Yeah.
that kind of stuff, and it just goes to 504.
Oh, okay.
So I'm just wondering, do you need to register before you start doing any of that, or you're not sure? Because that maybe
So
could be a glitch with my own system.
yeah, usually when you register via there, it'll take you to a different landing page where you can.
No, I'm doing it in reverse. So I just wanted to double check. So you do have to register before
Yes.
you can touch anything, like any downloads,
Yes. That's correct.
anything. Yeah,
That's correct. Yeah.
that's right. Because most of us
Yeah.
are doing. Oh no, I just want to read it first.
Yeah,
Yeah.
yeah, that's right. So there's descriptions of
Yeah.
what the resources are about, but to actually access the resources and tools and
Yeah.
e-learning, you still need
You
to
will have
register.
to register and then be able to
Yeah,
do that.
it's a
Yeah.
barrier for us. We don't like it too, but yeah.
No, that's fine. I'm just letting others know that.
Yeah. But I think for regulatory, we're requiring
Mhm.
them.
But John, the trainer,
Hmm.
What's your time frame on that one if we do book one or an
So-
organization books one? Yeah.
Oh, so that's really how I do the train is very individualized, quite bespoke. So I would meet with whichever group, say if they're from this particular organization, book a time with them, or particular home, book a time with them. Usually I encourage educators or really keen staff to be part of it, because what we want to do is to cascade that training
Yeah.
internally. Yeah.
Mm.
Yeah.
And how long does it take?
So the first session runs for about an hour, and then the succeeding sessions would really depend on, once they've determined which resources and tools they'd like to use further and would like to know more information, then they can just target it that way.
Okay. So in and this 1 hour one, it's generic on facilitating
Yeah. So
or
it's
initiating the conversation.
so the first hour, the session one is really focusing on introducing what the advanced project is about. So it's a more in-depth look into the relevance of advanced care planning, and also looking at the specific resources and all that. So it's really more of like an information session, so that they
Mhm.
know that when they progress further, because essentially the resources and resources kind of, it's very self-explanatory. It's me kind of cheering them on to do it rather than focusing on all of this training.
Okay, cool. And another question, I'm not sure if you have data, available data, but how many RACFs within in QPHN has already said, yes, we want this?
Oh, so we've contacted all PHNs to help us disseminate about this phase of the project. But currently, the biggest uptake would be in New South Wales of the residential aged care, who've done the trainer and who've accessed the resources and e-learning. There's some in Victoria, Northern Territory, so Western Australia, South Australia. Yeah, but I think looking at the recent statistics, I've got the biggest one in New South Wales.
Oh, so but then you are ready to receive
Oh yeah,
bookings.
absolutely.
Okay, cool.
Absolutely. Would love to connect with more people, and then I can arrange it from there.
Yeah.
Yeah. So
That's
would be great to have your help.
Yeah. We'll definitely socialize this because it is very it's a very good session to actually have with aged care workers to gain confidence in initiating the conversation.
Absolutely. A lot of it would really benefit someone who's probably new to advanced care planning or new to aged care, like myself when I was running away to do a dressing. But we also have resources that someone who's more experienced have done already, but probably haven't done it in a while, and just like, oh, what do I need to do again? Just have a quick reference and go straight to it. Because ultimately, this would depend on their communication style, on their relationship with the resident and family members, but really just having some way to prompt them or structure their conversation would just be helpful.
Right.
Yeah.
Yeah, like it's a very good guide. Yeah. Yeah. Brilliant. Okay. All right. Thank you for that. And we'll definitely we have your email address, yeah?
Yes,
And
yes.
so because we have more than 300 compassionate community connectors who would probably benefit on this guide, and if you could be one of the if you could be our speaker for the next health community connectors network meeting, that will be fantastic.
Right. Well, thank you so much for the opportunity to meet with you, and thank you so much for anyone watching the recording. I'll jump off now if there's no further questions. Just gonna dash to my next meeting.
Thank you, John, so much.
Thanks very
All right.
much. Bye.
Talk to you soon. Bye.